you could just tell us about your training and how you learned lap and then you moved on to robotics and how that led you to where you are today.
All right, excellent. That's a great question. I think it's a great start because kind of the inspiration to do this started really from the very beginning. So, I did my urology training as a foreign medical graduate in Cairo University, where I did my 6 years of urology residency. Then at that time, laparoscopy was really starting to become quite a significant feature. And so I spent about 4 years in Europe between France and Austria, where I was able to get the European Board of Urology, but also at the same time learn from real experts in the field on how to do laparoscopic surgery. Now, laparoscopic surgery was at that time, very difficult to master, given just the skill set that is required, the instruments that are utilized. And despite doing, 4 years and 2 certified fellowships, it did take a little bit of time where I kind of to understand the intricacies that were required. And it dawned on me that it took an initiative from my own self to be able to really advance my skill set to a degree. There was no standardized curriculum. There was no standardized way to learn, which was the way that we pretty much did fellowships approximately, a decade ago, or even 2 decades ago, which is volume. There were 7 cases in the OR a day, 3 days a week, and that volume was considered quite high, and you would just adapt it. We would start the case, but always reach a point where we wouldn't end the case. So there was a part of the procedure that you never mastered. And so I kind of found a sim lab that was there. It was set up. It was pretty much a very small corner room, and it had a tower and it had a lab trainer. So I started developing these things out of foam and out of soft tissues, crumpling up some paper and putting it in a glove and suturing different aspects of things, trying to replicate the different parts of a radical prostatectomy. And it came to a point where I really mastered a couple of stitches that were very difficult for me to do in the operating room, and realized that training outside the operating room actually made value. But I really felt that there was a big disconnect between what happened in the OR and what happened in simulation. Now, at the time I got proficient in laparoscopic surgery, robotic surgery started to become really the next technological adventure and the next big thing in urology. And at that point, that's when I went to the University of Rochester and did my 2-year fellowship. That's when I started reading a little bit about literature related to how people learn and the different training paradigms and different training curricula. And the majority of this was not in urology, it was actually in general surgery and different aspects of surgery. And so then I set forth my own curriculum. I started telling my fellowship director, this is how I want to progress through the cases. This is how I want to learn. The virtual reality simulator, that Intuitive, the first iteration of it actually was just arriving, and we just bought it. And I started practicing on that on weekends and after cases. And at that point, there was the concept of warming up before doing your case. And so I did all of that and started to feel that there was true value in really being able to train outside the operating room, but also training in a very structurized way where it's not only psychomotor skills, but it's also a lot about understanding the procedure and the different steps and the orientation. And so I used to record all my cases and actually used to record my fellowship director's cases and narrate them. And so I knew exactly what each step was being done and why it was being done, and then different aspects of cases that require some modifications.
Unbelievable.
So then I started as faculty, and that's when truly the passion of trying to transform everything that I felt was a hurdle in training and simulation into a true curriculum, but also a platform that would be truly realistic. That's when I started my research endeavor and started with a small project and a small fund that I got called the Dean's Teaching Fellowship from University of Rochester. And that's really what started it all about 15 years ago.
Unbelievable. And now you're at Hopkins and you've been continuing on to that. Yeah, so I think that for the listeners, this is a great to reference our last podcast, our last interview with Dr. Stifelman, who basically gave us the landmark changes that have happened from open to lap to robotic surgery and has led us to where we are. And I think this next question which I ask goes really well with that, is education. What was it before you told us what you did, but what was happening around you? How are people preparing, and how minimal was it, and where is it now?
Yeah, so open surgery was never really an issue where we needed training outside the operating room, because the training environment where you are a surgeon in front of your trainee, you are hand on hand, you are walking them through the steps, and you can correct any issues they have. So truly open surgery, when we were truly bedside surgeons, that was not really an issue where we needed to create learning outside, an environment where we learn outside learning on patients. It was safe, it was reproducible, and it also had a huge volume. So you could really use the apprenticeship method. Then when we shifted on to laparoscopic surgery, we reached this point where new skill sets were required. Hand-eye coordination, lack of haptic, fidelity, the idea that you have to coordinate suturing in a very difficult environment. All that required us to develop certain skill sets. And that is the time where our experts started to be trainees. And therefore, our trainees were left to the wayside, where it was very difficult for people learning a skill to teach
Sure,
a skill. And
sure.
that's when simulation really started to flourish quite significantly in the surgical field. Now move that into not only the fact that we have new technologies that are coming in every day. Even look at robotic surgery. Not only do we have one multi-port robot, but we have several types now. But even now, there's a single port robot, and I'm sure in the future there's even more than that. And so surgeons in practice are consistently required to train and retrain and maintain their skill set, therefore creating a very unique environment where truly realistic surgical platforms are required. Look at BPH. How many modalities do you have to treat the same size prostate gland now? About 40 or 50. As a resident, that is very difficult to master every single one of them, right? We had open prostatectomy and TURP.
Right.
That is it. Now there's almost 12 or 16 different technologies that you have to master, from aquablation to Rezum to steam to urolifts to whole lips. It is incredible the amount of new techniques that are required to be trained. And we haven't changed the number of years that we train them in, right? So urology residencies are still 5 or 6 years.
Right.
And so we're asking them to do triple the amount of learning in a more difficult environment of learning, where patients are more conscious about academic institutions. And and the number of times I've heard, "Are you doing the surgery?" regardless of whichever institution I'm in, is very common right now. So it's putting us in a very difficult place where, if we do not have training paradigms outside the operating room that augment training in the operating room, we are going to get to a point where we are lacking in our ability to deliver competent surgeons.
Right. It'll eventually catch up, reduced autonomy and the need for continued training, even after training, leads our next generation, including myself, of surgeons to be in a bind.